Hello, everyone, and welcome to today's webinar. Thank you so much for joining. My name is October Boyles. I'm the Chief Clinical Compliance Officer here at ICANotes, and I am thrilled to spend today with you talking about cracking the code and simplifying E&M coding for mental health. We're going to cut through a lot of the confusion, because there's a lot of it, around E&M coding, just and focusing on documentation that's audit ready, that's clinically defensible, and show you how just small adjustments in what you do can really make a big impact in compliance and definitely in your reimbursement. Wanted to get a feel of who's in the audience today, because whether you're a prescriber, you could be a practice owner, you could be a compliant lead, whoever you are, this session is really designed to give you these real world strategies that you can apply immediately in your practice. If you don't mind, just in the chat, if you wouldn't mind sharing what your discipline is and where you're from. I've always loved to find out where people are from. So just so you know, I'm from Charlotte, North Carolina, and it is trying to be cold here. It's trying to be cold in Charlotte. But yeah, just LMSW and NOLA. All right, fantastic. Great to have you, Brett. Great to have you. Fantastic. So I also see a lot of familiar names in here, so that's great. Absolutely. We've got a lot of psych NPs, psychiatrists, APRNs. Fantastic. All right. So folks in here, Arizona. Ooh, that sounds warm. Arizona sounds really warm. My neighbors in Virginia and Georgia. It's great to have you here. In the Bay Area of California, I'm slightly jealous. I'm not even gonna lie. Slightly jealous. Baltimore, Maryland, that is where our home office of ICANotes is. So it's great to have you in here. New Jersey, Maine, that all sounds very cold, but it's good to have you guys in here. Absolutely. Connecticut, Ohio, North Dakota, fantastic. All right, great to have you guys in. So we're just gonna be going through this today. I encourage you to ask questions in the chat. I'll get as many questions as I can. What I will tell you is there are 3 different ways you can communicate in this particular webinar. So one is the private chat that goes directly to me. I will tell you one thing about the private chat. I'm happy to answer questions in it, and if you don't want anybody to see your questions, stick them right in the private chat, but it does pop up and plot my screen. So if I get too many, I have to X them out and then I'll lose your question. You can put it in the public chat. Everybody sees it then. Just be aware of that. So if you have something in private you want to ask, I'm happy to answer that question. Won't say your name or anything like that. But in the public chat, if you don't mind everybody seeing it, just stick it in the public chat. I've got it there. And then there's a QA. And the problem with the QA is that is the last thing I could see on my tab screen. So for whatever reason, they make it where QA isn't easy to be seen. So that one is hard for me. So if you'll put it in the public chat or the private chat, those are the best things. But it's great to have you guys in here. It's absolutely wonderful to have you here. We're going to go through this. Now, I'm going to go through it quick. And there's a reason for that too. People like to get the webinars because you will get a copy of this webinar. If you signed up for it, any webinar with ICANotes, you're going to get a copy of the webinar. And you can rewatch that. You can share it with other people. And you can speed through if you want. But let's talk a little bit about why this matters. And the reason that this matters is because 1 in 3 clinicians underbill. And a lot of providers will kind of default to this lower code because they want to stay safe, but they're leaving really legitimate money on the table. And underbilling it's not just a financial issue, and we'll talk about the financial side today, but it also misrepresents patient acuity and that's problematic. And I see there's some practice managers in here too. So if you're trying to get data accuracy for the organization, determine how many acute patients we have, like what we're doing in the visits, that's really difficult to do. So this webinar is going to be about helping you feel confident matching your documentation to the correct E&M level. The other thing is overcoding increases audit risk and denials and a lot of compliance risk too. And those auditors are out there, they're looking for these pattern outliers. And if your documentation doesn't justify the level of billing, it's an automatic red flag. So that's what we're going to go over a little bit today too. And then also, if you're spending time and you're second guessing your coding, that's less time you have, right? Every minute you're debating, should this be a 99213 versus a 99214? It's a minute you lost for your patient care, right? So it's important to have really clear templates and good coding logic that reduces hesitation. And I'm going to show you some of that today as well. And then we're going to talk about how the E&M rules prioritize MDM or total time. Because some people get stuck on that. We have people out there that are they just stick time in. And so in 2021, the AMA updates it shifted focus away from like history and exam checklists, and it's now about complexity and time. And then the 2023 to 2025 revisions, they refine these time thresholds and they introduced that new behavioral health choice or codes to give you a little bit more accurate options. And we'll be going through all of that today. One of the common challenges that people get is, and CMS came out and said this. They did a review in 2022, and they said that over 40% of outpatient behavioral health visits are coded below their MDM level. 40%. CMS said that. So that's telling, right? So that really supports the idea that behavioral health providers, they often undercode due to, I think, a lack of clarity in transcribing the complexity MDM. So when we talk about using what's a 99213 versus 99214, we're going to go in depth. I've got some case studies for you, but it's one of the key common sticking points for clinicians. There's just a lot of hesitation between moderate versus low complexity. And there's no like documentation that clearly fits the textbook definition. We're going to go through that today. So the predictability here will protect you in an audit way better than guesswork will. All right. So the other thing is like when it's time to use MDM, again, time-based coding, that gives you flexibility. It's great for flexibility, right? But it really opens the door to errors as well. And so I think as a rule of thumb, I like medical decision making because I think it drives the visit. And I think that you can do your add-on psychotherapy. If that dominates the session, you can document that clearly. So there's some things there. We're also one of the things is translating mental health complexity in the MDM. You've got the three areas, right? The problems, the data, and the risk. Now, and a little bit, I'm going to drop the slides and we're just going to look at a layout that will help individuals a little bit more with understanding that problem, data, and risk. Because it's not, most of you, and how many of you, just out of curiosity, are behavioral health professionals? I know I have some folks in here that might do primary, but if you are a behavioral health professional, give me a thumbs up or say yes in the chat or no. So if you're a behavioral health professional, just give me like a little thumbs up. Know how many folks are in what specialty. I got yeses so far across the board. Private yeses across the board. All right. All right. Excellent. Okay. All right. Great. So I like to know who my audience is and who I'm speaking to. So this is great. So the problem is behavioral health. It's not black and white across the MDM grid, right? You've got depression severity, suicidal ideation. You got trauma complexity. Those don't fit neatly into those like two stable chronic illnesses, right? And so you kind of have to articulate the clinical reasoning there and the data that you reviewed and the level of risk mitigated and document that really clearly. Another thing as we go down to navigating incidents is like the incident to bill, right? As far as direct supervision, that is always a common challenge for people. And then I call it right sizing documentation. And you want to aim for documentation that's concise, it's defensible, it's aligned with the CPT elements. I love when people put justify level of care. And if you're like, what's your experience and your background other than like working for ICANotes? The great thing is I've got to work for ICANotes for almost 10 years now with ICANotes. So I am well aware of the billing complexities that mental health clinicians face. We have primary care in ICANotes, but we're majority mental health. And so another thing is before I came to ICANotes, I worked for a law firm, the largest one in the Southeast, and we protected clinicians. So if you're like a patient suing a provider, that we did not engage in that, but if we helped providers with suits. And I served as one of their experts as far as looking at cases to see, frankly, should we settle or is this defensible? And unfortunately now, one of my jobs at ICANotes is I do have to deal with federal and state level authorities when people have billed fraudulently. So that's never fun. That's not a fun part of the job, but it has given me an insight on what people are looking for, what these auditors are really looking for. And that's why I'm really heavy into compliance. And I feel like audit ready is better than overcharting all day long. And I have to be clear with MDM, like coding in behavioral health, it's not about picking the right number. It's really about accurately reflecting what you did. What was the cognitive work we did? What was the risk that was involved? What was the time? Because when all of that comes together, your documentation, tells a really clear story. All right. Got a question here, and feel free to put them in the public chat as well. But in the private, it says, what exactly counts as a structured MDM phrase? I like an MDM structured phrase to me. It's an interesting question. I like it though. It would clearly link like your problem, your data, your risk. Let me throw that out like problem, data, risk. So, patient with chronic depression. So, that's your problem, right? I would say reviewed PHQ-9, that's your data. And then your risk. Like I adjusted the SSRI due to side effects. Okay. So, problem, data, risk. And you'll hear that a lot through today's webinar. Question though. Great question. I love questions. So, feel free to drop them in. What you're going to walk away with today, I'm just going to go through this really quickly. You're going to be confident choosing levels. You're not going to guess between a 9-2-1-3 versus a 9-2-1-4. You're going to know how to distinguish low to moderate. There's no more hedging there, no more guessing. Basically, clear time versus MDM decision framework for selecting the right code. Again, behavioral health coding gets a little tricky because time and MDM both be legitimate, but they're not the same. And so we're going to give you a simple kind of decision pathway for that. And then we'll talk about exceptions. We'll absolutely will. And then mental health specific case studies. We're going to see real behavioral health case studies here, and then compliance proof documentation tips. I'll show you what to include and what to cut out. Okay. And then the next thing is revenue protection strategies. All right. This is really important. None of this, that I do want to make sure that people understand this isn't about trying to game the system, right? This is just owning your expertise and what you're doing with your patients and clients. And here's the thing, if you do the work and they have the acuity level, you deserve to be paid for that. And so many clinicians are not getting paid what they are worth and the acuity level of the client demands. And so that's something that is really important. And clinicians, time and time again, they undercode. You'll hear clinicians time and time again say, I didn't go into this for money. I understand that. And that's wonderful. And those are the kind of clinicians we want in the world that did not go into it for the money. But if you are doing the work, you deserve to get paid for that work. Do y'all agree with that or not agree with that? And you type that in the chat. Heather said, that's a great question, Heather. So E&M codes, like when we're talking about a 9-2-1-3 and a 9-2-1-4, those are evaluation and management codes, and those are only billable under prescribers. If you're prescribing medications, that's MDs, DOs, nurse practitioners, physician assistants, right? Those are the things. And master level clinicians, like you said, like you're talking like LCSWs, LMFTs, LPCs, they bill E&M codes because the coder that requires like a medical component, like medication management or physical health evaluation. So yes, but LPCs and other non-prescribing clinicians, they can you've got like your psychotherapy codes, like a 90832 or 90834 or 90837, those kind of things. Yes. So no, that's a great, great question. Great question. I think maybe this webinar is focused on E&M coding. That's basically my E&M coding. I am going to go into psychotherapy billing add-ons. I will talk about that at the end. But I think we will absolutely do a webinar on coding because there are situations where, clinicians, non-prescribers are not, they're underbilling as well. That happens all the time as well. So we'll do a webinar on that. So yeah, absolutely. All right. Great question. Great question. Okay. We got a lot of people agreeing that yes, I should get paid for what I do. Yes, absolutely. Absolutely. You should. All right. We're going to go into, let's see, E&M, the basics on outpatient. OIG came out in 2022 and they said in audits and documentation errors, not fraud. right? Not fraud type of audits. Those account for 88% of denied behavioral health claims. So your documentation really means everything. Documentation errors. I got a question here. Hold on. If I spend 28, okay, so let me read this out loud. Sorry. I'm not going to say your name if you're in private, so don't worry. This is the question. If I spend 28 minutes with a patient, but the MDM supports a 99214, which one takes precedence, the time or the MDM? A lot of people have this question, like, should I use the time or should I use, I'm going to tell you, you always code based on the element that will best represent the work performed. So if the MDM meets the 9214 and it overrides the time, then you do that. Okay. Because look, the MDM reflects decision making complexity. It's not clocking your minutes, right? It's not clocking your minutes. That's the thing. So you're going to build that MDM 99214. Absolutely. So Kendra said this would be helpful me to understand how it worked. You did it. Yeah, absolutely. Absolutely. No, sounds good. You stay right in here. Absolutely. And I'll answer any questions you have. I want to clarify the 99215 time range as you're looking at the time code requirements there. The CPTE list, it's 40 to 54 minutes on the 99215, right? But there's technically like an open-ended upper range where the total time meets or exceeds that 55 minutes, and you can consider like a prolonged service code, like a 99417 if it's not Medicare, and it's a G2212 if it is Medicare. Okay. So I want you to think about that because how many of y'all use prolonged service codes? How many of you use them? I'm interested to see in the chat how many people use them. We should have had that as a poll question because there are a lot of people that don't use them when they could be using them. And that's okay if you're not. This is just something to take away from the day. Juanita says we have. So yes to G22. Good. Okay. I've got some people. So it's varied. I've got some people saying yes, some people saying no. I'd really look into that because now some actually you're right. Some payers, they have really specific rules and they don't want to pay that out. And usually when you first sign up with them, because they're very specific about that in your contracts that you sign with them, and those are updated. Yeah, I know that the telehealth code has really been a source of contention for a lot of people because they'll use like a standard telehealth code and then one insurance company will come out and be like, no, didn't you read our paperwork? You're supposed to use that code. And it's just not okay. It's not okay. Absolutely. Let's just be real. Insurance is going to do whatever insurance can to not pay you. And I hate that this is being recorded right now, but I said that out loud because it's true. They're going to do whatever they can to not have to pay. Absolutely. Let's see. Somebody said, what if the documentation doesn't support the MDM where there is an audit? I would suggest using time. I think that's a fantastic point. If the documentation doesn't fully support the MDM level during an audit, time can be safer. But I think that we should look at maybe your documentation just should clearly support the method you choose. Like, even if it doesn't show enough complexity in the problems or data or like risks for a 9214, but you legitimately spent 32 minutes providing care, you could bill on that time 9214 based on time. So yeah, time can be your safety net when the MDM isn't fully supported, but you need a solid total time statement. And if you're dealing with Medicare and Medicaid, I will tell you one thing I've seen: be really careful when you're scheduling people on your calendar because especially Medicaid, the first thing they'll do if they're going to run an audit on you, a lot of times is they'll come and they'll pull your calendar. And then that does not always paint the picture of the time that you want it to. So be really careful. In ICANotes Classic, I'll tell you one thing that we do is if you like some people double book, it is what it is. It happens. But we won't allow you to double book if it's a Medicare or Medicaid patient. There's a group rule. We do allow that in general because it's your calendar and you can do what you want with it. But if you're worried about that, a lot of practice managers will turn on, don't double book a Medicare or Medicaid patient. So, because that's the first thing they'll come in and do is pull that calendar. So, I'm just telling you what some people do. They'll set up like they'll have two different calendars. We'll say like it's Dr. Smith and Dr. A. Smith. So they have two different calendars. I'm just telling you what other clinicians do. So just to be aware. All right. Let's see. Not there's some other codes we don't really talk about too much. There's a 99211 that is a nurse only or like minimal service. That would be like you check their vital signs or there was a brief medication review. Like it's not based on time. There's no MDM. Clinicians should not bill that code ever, the 99211 ever. So absolutely with that. So you want to keep your brackets sharp, right? You've got, and I've got them displayed here on the screen for you. Absolutely. All right. All right. Let's keep moving on because I want to make sure I get through all these slides and your questions and I can be windy. Yeah. Thank you again. Thank you. Thank you. All right. So let's go. We're going to talk about the case study here. I will tell you that there was a coding and compliance benchmark that came out. It's MGMA. They came out in 2023 and they said up to 60% of psychotherapy with EM codes are billed incorrectly due to the time versus MDM confusion. So just to kind of throw that stat out there. Again, when we're talking about numbers here, we're not talking about like 10% do it or 15% do it. No, we're talking about like 60%, 80%. These are huge numbers. So Susan, I'm sorry. Yes, we will send this to you. Absolutely. Yeah, don't worry. This webinar will be sent to you so you can review. I know I'm a fast talker, so I'm sorry, which is funny because I was born and raised in North Carolina, right? And there's misconceptions regarding that. Good question here. If a patient completes a PHQ-9 and you discussed coping strategies, why doesn't that qualify as a moderate MDM instead of low? On this slide? On this slide you're talking about? Okay. So yeah, the patient on this slide, when we have case 1, this was a low MDM. They absolutely, they did a PHQ-9. But if you'll notice down there under visit activities, there was no medication change. There was, or new risk introduced. So this visit really focused on monitoring a stable condition. And that keeps the data and the risk at a low level, even if you're doing supportive counseling. But this kind of case study is it's a bread and butter example, right? You've got a 32-year-old with GAD. They're stable on a SSRI. They did a PHQ-9. They had mild symptoms. There's no side effects. There's no medication changes going on. This is a low complexity visit now because there's nothing acute. There's nothing unstable. It's just ongoing management and supportive therapy. So there's probably like a brief chart review done. They checked on symptoms and side effects. They reinforced their coping strategies. There's no new data review, right? Beyond the screening tool. And there wasn't any medication adjustments. So that's what keeps this low. Now, if we break it down by MDM, when you talk about problems, this is one stable chronic condition. It's GAD, it's managed, it's unchanged. We talk about data here, it's limited. You reviewed the PHQ-9, right? But that's one minimal data point. And the risk is low there because there weren't any medication changes, there weren't any new therapies, there weren't safety concerns, right? So you could also code it by time. It shows 22 minutes. And that also falls in, if you take the 20 and the 29 minutes, that falls into the 99213. Either way, your outcome is going to be a 99213. It's appropriate. It's defensible, right? Absolutely. But here's the key points with the documentation here. Here's the key point with the documentation is that you have your problem. It's stable. You did your screening results. It's mild. And you did a brief counseling. That's it. So how many of y'all would have agreed to the code 99213? How many of you agree to the code 99213 in this one? I'm getting yeses in private. So a lot of y'all blowing up private chat. I love it though. I love it because it pops right up on my screen, so I see it right away. I got public chat to say Juanita to say me. Yes, absolutely agree. All right. I got some questions here. Just want to make sure that I get them both. And what if you assess 2 to 3 problems other than GAD and a couple of medications? Will that increase complexity? This is a beautiful question. It's one of the core judgment calls in behavioral health coding because it really shows you've got this advanced understanding, right? Yes. So yes, if you address 2 to 3 problems other than GAD and a couple medications? Absolutely, it will. You're going to address multiple problems, right? You're managing probably more than one medication. So yes, absolutely. And you could even the CPT defines it as problems actively managed or monitored during the encounter. Okay, during the encounter, not just what's on that problem list. So I think a lot of people confuse that. It's problems actively managed or monitored during that encounter. Absolutely. Yeah. And that another thing is the MDM, it doesn't rise just because like you listed more diagnoses, right? It rises when each one requires the clinical thought, the documentation, you're making those decisions. I hope that helps. So when your psychotherapy and your E&M are built together, the E&M must be chosen by MDM only. Like that, the time no longer applies to the EM portion. I hope I made that a little bit easier. Here we go. So I want to make sure. And I want to show you something we have in ICANotes that is going to make this a lot easier. I'm going to move to my next slide, but yes, you are going to get this in recording. You absolutely are going to get this recording. Absolutely. But I want to show you something that's going to make it easier. Okay. So this is Plus. If you haven't seen Plus, this is what Plus looks like. All right. I'm going to go in the chart room really quickly and I'm going to show you. So this is a prettier version of it. Hasn't been released. It's in like, it is not, it's not 100% through beta. So I don't know what it's going to do to me, but this is the coding matrix here. And this makes things very easy for individuals. But I think this helps when we just roll down through. And so let's just talk about these. Now, as you see right here, I have my time. Okay. As you see right here, I have my time. But here's my coding matrix over here. And so you have, and our problems addressed on the wall, you have the stable chronic illnesses and minor problems. Now, a lot of people get confused in this area. So let's just go through this really quickly. Minor problems are like, because a lot of people have differentiation with this. If they have situational anxiety, like they've got a recent stressor going on, okay, like a job stressor, or they have a brief grief reaction, or there's an adjustment period, or there's just some type of mild situational depression without functional impact, that is a minor problem. But let's be really honest with you. Most of all of you are prescribing mental health professionals. If they have minor issues, they are not seeing you, right? Because they might go see their primary care or they might just talk to their like best friend or neighbor about their issues. But if they're in seeing you, these are probably not minor problems. What we're talking about here is going to be chronic illnesses, right? And that's not it. You might have one person that comes in that you treat really briefly and leaves. But for the most part, you're seeing people with stable chronic illnesses, right? They got to you. There's definitely something going on. And that's generalized anxiety, major depression, ADHD, PTSD, chronic insomnia, OCD, all the things, right? All the things. So these are your stables. These are your acute, uncomplicated illnesses you have there. You have chronic illnesses with exacerbation. People have a lot of questions with this. If chronic illness with exacerbation, they'll say, what does that mean? It's exacerbated. It's worse. That means if they have GAD, your walls and water disorder, they're having increased panic attacks. They're having restlessness. If they're having bipolar 2 with increased hypomania, they have PTSD with a new trauma trigger. They got the ADHD and they've got declining focus and their work's impaired. So if there's substance use disorder, they're craving. That cravings come up. It's resurged. They may have relapsed, those things. That's exacerbation. We talk about chronic illness with severe exacerbation because a lot of people, they don't fill this area out. This is when you're talking about like active substance relapse, panic disorder, and they're having frequent, severe panic attacks. Their functions impaired. Bipolar 1 and its significant mood instability, severe insomnia. Now they're teetering on might be seeing things. Their medication is not responsive in this area. And then of course, let's just go over acute or life-threatening illnesses. This is suicide or homicide. Everyone in this room knows this, but a lot of times if people are having a psychotic episode and it's brand new, or they've had hallucinations and their delusions and they're worsening, that's acute or life-threatening. Okay. If they have violent, unpredictable behavior, acute mania with high-risk behaviors, they're they're out, they're spending a lot of money, they're being sexually promiscuous, they're putting themselves in bad situations. If they're acute, they're having an acute dissociative episode, like impairing their safety or reality testing, these things. And you can really add them all up. Let's say that it's an acute illness that they have going on, or perhaps they have a chronic illness with exacerbation. Let's just go ahead and hit that. It'll give me a moderate. It tells me what it gives the codes here. So moderate. And then a lot of people have questions. And is this helping showing the matrix? I want to make sure that this is helping, that seeing it out. Because the one thing for me to talk about it and to be on a slide, but to show, I think, is different to show how it actually works. Okay, I got all of it. Okay, okay. So going through it, and then let's talk about data, because people are very confused about the data and they don't make it really easy to understand. Okay, so this with data, let's talk about like external notes reviewed. Let's talk about this one. So I want to highlight it as we go. External notes reviewed. This is documentation for other providers. You already know that, right? But this could be a lot of people, they don't think about if you're looking at a PCP note and you're looking at the thyroid labs, right? And looking at like maybe they had fatigue symptoms or something like that. That is, of course, that goes down. If you're looking at a psychiatrist, like a prior discharge summary from hospitalization from the psychiatrist, that is an external note. If you're looking at therapist note, you know that, right? Everyone's, yeah, nope, got that one. But pain management notes can be included in that, case manager notes. So it could even be if you're dealing with children and you're looking at a school counselor letter, that is an external note. Anytime you review an inpatient discharge plan from behavioral health, that is an external note. Even if it's just one external note, you definitely document that. External test. If this is a PHQ-9 or a GAD scores, maybe that was by the therapist and you're looking at that. A lot of people, like maybe they review a sleep study from a sleep doc. Okay, that's it. If you review a urine drug screen, if you're looking if they got pain management and you look at their urine drug screen from that pain management provider, absolutely. With labs, if you're looking at TSHs, CMPs, CBCs, anything like that, lithium levels there. But maybe they went like they had some neuropsychologist testing done from a psychologist. This is I'm sorry, I highlighted we're here, external test review. So one thing that people miss a lot, keeps highlighting the wrong thing. So sorry. External test review. There we go. If you review genetic testing, like maybe like GenSite, that's the only one I can think of right now, but there are a lot of others, and you review genetic testing, that's something. Now, in your note, you got to mention what you did with this, right? Especially if it was like, let's say it was a lithium level. Review lithium level, 0.4 will increase the dose of recheck, right? You've got that. So test order, anytime you put in a test. And I think this is basic knowledge, but one thing is people like they forget like urine drug screens absolutely count on this. A lot of people do those, but a lot of people think labs. It's not just labs, it's urine drug screens. If you get an EKG on somebody, like somebody's going to go on stimulant therapy and you get an EKG, that is absolutely a test. Even a lipid panel. Think about tests too. Ames assessments. Think about that. It doesn't have to be a lab test. So some people will order like Ames tests to be done by staff and they can count that in too. And I have not heard anybody balk on that. So absolutely. And then I have, yes, absolutely. Somebody said, yes, absolutely. Now, any new order, so any new orders there, independent historian. What do you guys think independent historian is? Independent historian. Tell me what you've used in the past for this. Independent historian. I'll say a lot of people forget or don't hold them because they just bypass it. But anytime you get collateral from a spouse, anytime a parent talks to you about their child's sleep, if you're seeing children or eating or aggression, anytime you get feedback from a caregiver, if the teacher has a report, if the family member provides context or suicidal ideation, yes, absolutely. Anytime. Very good. Some of you. Do y'all put in historian? Talk to me about if you use this a lot. Because as much as families are calling, we literally have a note we created in ICANotes called the quick note, and people use it for a no-show note a lot. But a lot of people use that note for collateral information. Absolutely. Very good. Now, the other one that we're talking about is independent interpretation. Independent interpretation is when you personally interpret data or results rather than relying on another clinician's report. Maybe it was you got a PHQ-9 or you got a GAD. There's a gray line here. So everything else I'm telling you is like concrete, but there's a gray line here. If you independently interpret PHQ-9 and GAD-7 scores, there are some clinicians that are saying, well, in the portal and I interpret it, that they are using that. That is a gray line. I don't have a whole lot of data on that. But if you reviewed and interpreted a urine tox, that's fine. If you interpreted labs, if you interpret, I don't know if any of you doing, maybe, because a lot of clinicians now are looking at sleep data logs, their Fitbit readouts, things like that for sleep hygiene. If you interpret any of those data, a lot of people say, I'm not a lab tech. I don't interpret data like that. This is your clinical interpretation and how it affected your plan. Absolutely. Very good. So those are those things. Yes. So I just got a discussion and management, or so I'm moving on. I've got your questions. I'm sorry. I have a lot of private questions that have popped up. So when you talk about consultation or case discussions with another provider about the same patient, let me highlight this one. Sorry. This is if you're talking about medication overlap or blood pressure concerns, anything like this, if you coordinated care with a therapist about progress they're having in their trauma treatment, or you discuss patients' medication adherence with the pharmacist, you absolutely. How many, out of curiosity, use the discussion and management? Have you ever used it? Have you ever used it? Just out of curiosity. Saying no's. I'm getting so much in private, so sorry. No's. Okay. No's across the board. My old screen popped with no's. Okay. Fantastic. Fantastic. All right. So no. Okay. Excellent. Excellent. So that's one of the things is that this discussion and management people don't utilize. If you have let's say you spoke with the social worker, they have a social worker about a community source kind of linkage situation. If you talk to the patient's like pharmacist, if you discuss anything with the patient's pharmacist, if again, you're coordinating with therapists or social workers, you always know who you spoke to and why, but that qualifies this data element, right? It qualifies the data element. And so that's one of the really important things. Every time you read, review, or coordinate, that is all data. And if it informed your medical decision, it needs to go in your note because the data tells like a story of what you're thinking. These are all of the things that I did with the individual, right? Now let's talk about risk. This is an area that people a lot of times get hung up on, right? So let's talk about the risk behaviors. And because we're running short on time here, so I want to make sure I go through this. Risk is the likelihood of the patient's condition on your management plan that could make them require higher level care, or lead to significant deterioration. The risk can come from your three sources. What's their presenting problem? Are they severe? Are they unstable? What's their diagnostic procedures? What'd you do? And then your management decisions, right? And so you have your minimal risk. And so I can put some things in here like maybe I did an internal note, maybe I did two internal tests, and I spoke to an independent historian, and then we did some discussion and management. And see, now it's got me up there at high, and I'm at a 99214 already. I'm at a 99214. Now, what the matrix won't do is it's not going to pick your risk because it wants you to pick the risk. But let's talk about risk. Risk is like a low chance of anything clinically happening to them. If they discussed mild situation anxiety, if you monitored like they have insomnia going on, if you did like Lexapro and you increased it on their Lexapro, that's low. There's a low chance of harm, clinical change. Moderate risk is where a lot of people feel really, really comfortable. No, I just got a question that popped up. No, if it's minimal, no, they wouldn't be seeing you if they were really at minimal risk. Okay. And listen, I know that might make you feel better to put them at minimal. No, they're good. Minimal risk. No, but they wouldn't be seeking your services if it was minimal risk for a lot. Now, again, I'm not telling you as a clinician what to put down. Everything I've talked about, you will all use your clinical judgment. I'm just helping you understand what these things mean and how the matrix kind of works. I'm sorry, Karen, I'm getting a lot of questions in here. So, absolutely, lots of questions. So, let's just go over the moderate risk though. Meaningful clinical decision making or medication changes with a moderate risk. That means that you did something that for potential moderate adverse effects, right? You adjusted an antipsychotic because they had maybe side effects, or you started or you changed a medication, and that requires monitoring. So anytime you start and change a medication, think about that as far as I gave them a new SSRI, I added additional medication, any kind of worsening depression or anxiety, but it's not an immediate like safety concern. If you had to coordinate with someone, if you had to go talk to their therapist or their PCP, that's significant, right? If you put them on a new sleep aid, like you gave them trazodone, and that wasn't part of the original, like originally what you're treating them for. If you discuss suicidal thoughts, but they don't have an active plan, if you had to create a safety plan for your patient, that's moderate risk. That's absolutely going to be a moderate risk. So if they're suicidal and you create a safety plan, that is a high risk. That is an absolute high risk. And that let's just move on to high risk since we already went there. Active suicidal or homicidal ideation is going to be high risk. If now we talked about changing medications, but let's talk about high risk medication. When you think of whole medication, tell me some of the things that you think of. What are high risk medications? Somebody in private chat put all. Think about high risk. Think about high risk medications. I'll tell you, anyone taking medication at any time is a moderate risk. I would say if they're taking medications, that's a moderate risk. But high risk medications, what I think about is like lithium, clozaril, and MAOI. Those to me are high risk. Yep, Harold, right in there. Arlene, and oh, yes. Especially if someone's a high dose Seroquel, like high dose Seroquel. Yeah, that's a risk. That's a risk. Absolutely. Controls, really good. Yep. Juanita, absolutely. Controls. Very good. Excellent. See, you guys have this. You have this. So if you're cross tapering two psychotropics, if you're cross tapering, that can be high risk. And think about it that this way, an auditor can't really fuss with that because if you're looking at CMS and I don't know how many of you, if you have a certain amount of Medicare, over 200 Medicare patients or a bill, I think it's over $90,000. And don't quote me on that, but I believe that's it for the merit-based incentive program. One of those things is you're supposed to watch if you have antipsychotics in the elderly. So you can say that is high risk because CMS guidelines actually cross over on that, right? If anybody has severe worsening of symptoms, like they have potential hospitalization, you've kept them out of the hospital at this point, but it's potential. If you're coordinating, if you ever have to coordinate with a crisis team, or they go inpatient, or they go to a behavioral health emergency department, or a regular medical emergency department seeking behavioral health care. And if you ever have a patient at risk for self neglect, if they have a risk for violence, or ever have a risk for medical toxicity, those are all high risk. And that's a 99215. That's a 99215. So if you're looking at it just from your risk, if we were to remove these, I don't know if this is going to work. Okay, let's try it. There we go. So if we look at this, for minimal is going to give you a 9212. Low will give you a 9213. Moderate will give you a 214 if I have these indicated, and high, and again, it's beta. So it's not working right. High is going to be like a 99215. And again, risk is where your clinical judgment is really going to show up in the record. It's not about how long the visit was or how high the stakes were, but it's really about you adjusted the meds, you managed the side effects, you assessed the safety, you already introduced the risk there. Now, what I will tell you is I already have I have slides that I didn't even go through. And thank you. Thank you very much, guys. Thank you very much. I have some slides I didn't even go through. I can try to buzz through those like within 2 to 3 minutes. Excellent. All right. So I'm just going to blow through these real quick. And I am not sharing my screen anymore. Sharing, stop sharing. So basically with this, these are a documentation checklist here. I just want to go through a few of these. These are common pitfalls to avoid. I really want individuals to see these. Under documenting, you don't want to do that at all. Uniform visit lengths. People say, I bill 45 minutes or I bill 16 minutes. Don't do that. If you don't always bill 16, do 17, 18, 42. Don't always have the same time frame, because I'm going to tell you that is an automatic red flag for auditors. I'll be with psychotherapist though, sure. Yep, I'm happy to do that. But don't ever use the same time over and over again, because that's an automatic red flag for auditors. And I even had an auditor one time brag to me that was the first thing she looked for. So please be cautious with that. Please be cautious with that. And start times and stop times, make sure that those differentiate when you're using those psychotherapy codes. I know we didn't go in depth with that, but that's one thing that I want to go into. We talk about revenue impact. You guys want you to see this. This is Medicare reimbursement. Most of the time in your private, your insurance is going to be higher, right? So this is the lowest estimate of how it will impact you per year, just with these visits. And also, we only did this on 100 established visits per month. How many of you do more than 100 a month? How many of you do more than? Yep, a lot of you. Yes, I'm getting a lot of privates. Yes, more than 100 a month. Absolutely. But just at 100 a month, look at the difference. And that's a minimum. Listen, guys, I didn't go. It's really probably closer to $36,000, right? So a red flag for therapist notes. That's a really good question. I think that just like people that are like, I did 45 minutes or 50 minutes and they do it on the dot. And you guys know, you never close out your sessions right on time. They might end a little bit early, but like they might go a lot later too, right? So absolutely. Don't that time. They love that. So auditors love that exact time frame, because it just lets them know, because they think if you are not documenting your time spent, what else are you not documenting? So just be really cautious about that. Absolutely. I'm going to have to wrap up. There are just a few other things in here. Audit proof your practice. These are some of the things you can do. I think these are really important. So I just give you that. And I will tell you, our handouts are up at the top. You can absolutely grab those. I think those are really good notes. And so if I come in here and I want to show you how ICANotes does this and codes a little bit. Let's say we have 2 chronic illnesses. Yeah, I'm just going to run through here. Actually, let's just do high. All right. So what ICANotes does is it will put in the note what is going on. Now, let me tell you why it does this with the MDM coding. It's because it puts it directly in this at the top of the wall. If you notice an icon is at the top of every note. I don't know if you still see my screen. Probably not. But we put whatever you put in the MDM code goes at the very top of the note, because when auditors look at your note, the first thing they see is person had 2 chronic illnesses with exacerbation. I reviewed an internal note. I ordered a test, and I had 2 independent historians that talked to me, and they see that at the top of the note. And a lot of times they stop because they don't want to read your whole note. If you have it there at the very top, they just stop. So that's one thing that I think is great. That's what we do. We have very few people that have issues with that. I want to have the Q&A and resources guide there, the AMA CPT code, guiding the APA, coding and reimbursement, behavioral health compliance, insight reports there. So that's one of the things. I answered a lot of questions. I hope I was able to answer all of your questions. I don't think I was, though. They were coming pretty fast, so I apologize for that. But thank you so much for your time today. If you haven't seen ICANotes Plus, it's it looks a lot nicer. It works a lot faster, and we are getting all the feature sets built in that. So I think that's a really good thing. I do again want to just tell you thank you for coming to this webinar today. And I hope that this helps increase your billing. I do. Now, I had some all I didn't answer it, but they said they actually just put as a question was a question, and I just bill a 99214 all the time. I do not recommend doing that. I do not recommend doing that because you can get on their watch list with these insurance companies and they can deny you. I had another question about someone who had been denied in the past. What I will tell you is, in my experience, when individuals get denied by the insurance companies or they have to go into a clinical review where they'll be reviewing all your notes before you submit them for billing, those are bad waters that you don't want to be in. I have had several situations with clinicians, though, who have fought that. I have had some clinicians that did not win against the insurance companies, but I will tell you there was a big group of clinicians. They got a great attorney and they won a lot of money against the insurance companies who said they weren't going to reimburse the 99214s and the 99215s because this particular practice had an acute clinic. They saw the SPMI population, SPMI, severe persistently mentally ill, and they saw that population and they were billing those high codes deservedly. There were a lot of case managers involved and they're working with PAC teams, and a lot of their folks were in and out of inpatient hospitalizations. And so they won that. So I guess what I'm trying to tell you is don't be afraid to bill high and don't second guess yourself. If you're doing the work, you deserve to bill at the rate that you should be able to bill according to MDM matrix. And so if you take anything away from this webinar today, please know that do not be scared to and undercode and short yourself and short the acuity of the patient, because that doesn't tell the true picture of the patient. All right. Again, guys, thank you so much today. I hope you all have a wonderful day. All right. Thank you. Thank you. Bye bye. And we will do one for therapists and I will do one on psychotherapy codes. All right. Those are great suggestions and we'll make sure to get those out. I'm going to bring in some advanced fillers on those because that is something we don't have a coding matrix, but there are areas that you're missing out on the psychotherapy add-on codes. And so we really talk about that. Get some of my RCM advanced billers in on those. All right. Thank y'all so much. Y'all have a wonderful day.